Welcome back. This is our third video. This is video 3. We're going to talk about clinical management with respect to tissue-specific impairment. In other words, what we found during our clinical exam, and then how we want to go about treating it using what we just discussed in video 2, our palliative, preparatory, corrective, and then supportive categories of treatment. So just before we get started, a couple principles of treatment. I think it's obvious that we don't want to do harm to our patients, but that is one of the first tenets is to do no harm. We're basing our treatments on accurate diagnosis. This is the tissue-specific impairment pieces that we're talking about. We're really trying to do a good quality exam so that you have good quality information and that you will then have, as a result, good quality treatments and outcomes. We want a specific treatment with a specific aim. In other words, if I select something that is not going to get right at the heart of what's going on early in my treatment, then I may be prolonging the plan of care, or I may simply just miss the boat altogether with actually treating the true cause rather than just kind of palliating the patient, treating the symptoms. We're trying to cooperate with laws of nature and respect how people move through the phases of healing. We're being realistic in our treatment as well as being practical. I'm not going to give somebody 15 things to do at home to be supportive. I'm going to try to give them 1 or 2 things that they need to do until I see you again, rather than 6 or 8 different activities that are doing the same thing. That's not even a good way to go about it. And then we would like to select treatment for your patient as an individual, respecting their functional ability, what they may have in their environment at home, also their work schedules and everything else. We're trying to put all those things into the treatment that we may be providing for them. Choosing our interventions. Some of you right now may feel like this guy here, just kind of throwing a blindfolded dart. But really what's guiding our decision making on these interventions is what we are finding throughout our examination, and the subjective activity that we did back in video 1, where we really try to dive in and try to figure out what's going on from a functional standpoint, looking at patient severity, looking at the tissue reactivity, how irritable is the tissue, helps us understand how aggressive we can be with that tissue. And then the stage of condition, how far out are they from the injury, helps us understand how we might intervene on their behalf. And then are they getting better as we would anticipate, or are we seeing them kind of lag behind? How is it healing? How is it not healing? All right, so what we're looking at is tissue-specific impairment. If we're defining what is a TSI, it is simply a specific tissue with a specific impairment. I know I used the word in the definition. We're not supposed to do that, but in this case, it makes perfect sense. It is a specific tissue with a specific impairment. So we have identified a specific tissue. We identify how it's impaired. And then we identify the direction and side, right or left. So here we have some examples that are not TSIs. They're vague: shoulder impingement, patellofemoral syndrome, decreased range of motion, or lateral epicondylitis. All of those do not have either a side or a directionality associated with them, therefore not specific tissue impairments. So if we look at some incorrect statements over here on the left, we might ask you to come up with a correct statement. So for instance, swelling over the anterior knee is missing a side. So we might say edema over the anterior lateral aspect of the right knee. If we looked at the next one, we might say tightness of the left rectus femoris versus quadricep muscle. Yes, rectus femoris is part of the quadricep, but it is one part, and that is the specific part, because we know that there are 4 parts to the quadricep. Typically, it's the rectus femoris that's involved, as it is the 2-joint muscle. Okay, our next one, effusion, right side, and the specific place for the effusion, knowing that effusion is a joint-specific swelling versus edema, which we'll see here in just a second. Here we've got an adhesion of the right first MTP in the dorsal direction, which would be limiting extension range of motion. And we keep going, looking at the left radiocarpal joint in the dorsal direction. Ligamentous laxity would be translated as to a partial tear of the right ACL. And then here's our edema in the anterior glenohumeral joint on a directional side, which is being covered up by the cameo here on the slide. So there's a few more for you to try if you'd like. You could stop and see if you can kind of get the answers before going to the next slide. I'll give you that opportunity here. Okay, next slide here gives you the answers for all of these, and you can kind of try to work through those. So our next slide is going to be a concept map, which is essentially your brain on paper. It is something that I used in teaching at the DPT program level. I found it helpful because it really kind of explains the approach both in a linear and a consistent manner so that you don't miss something. So again, your brain on paper. If we looked at all of the things that we were just discussing, our tissue-specific impairment, the tissue's reactivity, the stage of condition, the subject's functional losses, their reactivity, and then their functional goals, all of those things can be put together up here at the top, and then we address them through our categories of intervention, which we've already discussed in video 2 as being these 4 levels of treatment. And so all of this is going to come together for us in a case study next. And you can download that case study using this QR code. I'll give you a second to kind of do that, and then we'll move on. All right, so in the case study, your patient is a 35-year-old stay-at-home mom. They fell, broke their finger. She was in a splint for 5 weeks. Doctor now says it's time to remove the splint, and afterwards, they're having a hard time gripping items, in particular, tennis racket, which she is currently unable to do and therefore comes to therapy. So what we're going to do is look at the case, and you will get all of the little pieces in the case. These numbers correlate to our concept map from earlier and help us really to decide what is the problem in that category. For instance, tissue-specific impairment, we find that through using passive range of motion. Go back to video 1, you'll understand where we're getting that information. We have an end feel with an adhesion feeling in the volar direction. So they're unable to grip, which would be flexion activity of the hand. And so this is making sense. Now we have an adhesion in the volar direction, which would limit flexion. We have an adhesion, it's decreased glide. Therefore, our tissue-specific impairment here is adhesion of the MCP joint in the volar direction of the right hand, and specifically the second MCP. If we look at the reactivity now, that would be on the concept map, that would be the second box. We're finding that the tissue reactivity, or the tissue irritability, another word that we could use for that, is medium to low. There is no pain at the end, therefore low tissue reactivity, which tells us inherently, kind of tells us that we could be a little bit more forceful or a little bit more aggressive with our treatments. Their stage of condition Remember from video 1, we said if you are immobilized and you come out of that splint, you are automatically in the subacute category. In most cases, you've been in the splint long enough for something to settle and to heal a little bit. So you've moved from that acute stage into the subacute phase. We get those pieces of information from both our history and PFC, which is palpation for a condition. So we're looking for warmth, we're looking for redness, we're looking for soft tissue edema or joint effusion. So here's our history piece. The splint was just removed, so palpation for a condition says there's no swelling, there's no warmth, therefore they are truly in the subacute condition. Helps us understand their stage as well as their time from the injury. And we're using all of this to start to gain, okay, what are we going to do with the patient? And our last piece of information really helps us with functional goals. And what we want to try to achieve here is the subject reactivity. Says that they cannot grip a tennis racket. Therefore, for tennis, the subject reactivity or severity of the subject for tennis would be high because they're unable to grip a tennis racket. And so functional goals might very well be, I want this person to be able to grip a tennis racket and hit, 15 underhand cross-court shots. That might be a specific goal. Interventions, we're using the 4 categories of intervention. The palliative, which might or might not be used in this case as they're subacute. They're not in a whole lot of pain. So we would then use kind of preparatory activities, get into the corrective treatments that we would do, and then we would use a supportive activity for the home